comments either way.
Okay.
All right, we'll get started. So I know Adrian Hendricks changed the lectures around a little bit. Did you guys get this lecture yesterday or to prepare? No. Okay, so he sent you something else about neuraxial anesthesia? No. Oh, maybe something. Okay, that's fine. Last year I created a narrated version of this that you guys looked at, so I just want to make sure if you have already seen this entire lecture, we'll go really fast. We'll spend a little bit more time. This is obviously a huge topic, but this is just meant to be a quick overview, kind of giving some basics. Have any of you guys gotten to do spinals in the OR, in the joint room or anything? Okay. You'll end up in that room a lot this year, so you really get to kind of practice hand technique. And this afternoon, what we'll do is a quick PBLD, and then I brought a bunch of bananas, actually a really good simulation for the ligaments and everything, and we'll play with a bunch of different needles and get the Blue Phantom back simulator out and just kind of practice hand technique and that sort of thing. So more hands-on this afternoon. All right, so talk a little bit about anatomy and then kind of mainly focus on spinal, which you'll be doing most of this year. We'll play around with the epidural catheters and needles this afternoon just to, again, kind of see the differences and practice some techniques. This is a picture you guys are all familiar with from medical school, but I think really just kind of emphasizing what the shapes of the back are and the shapes of the spinous processes, which is important when you're doing your actual procedures because of the angulation that you might need to take. So you can see thoracic spine has kind of this kyphotic curve versus the lordotic curve of the lumbar spine. And when we zoom in on them, you can really see the spinous processes, how in the thoracic spine, they're pointed down, and these spaces are pretty narrow, versus the lumbar spine, they're almost coming out parallel to the ground, and these spaces are huge. So that's why we talk about midline and lumbar spine is pretty easy to get in, while in thoracic spine, sometimes you can sneak it in midline, but sometimes a paramedian approach, kind of coming into those spaces from the side, is easier than trying to get up and under those spinous processes. So you can see, right here, that's a pretty hard thing to hit exactly just by touch. The overall, kind of the top-down view of the vertebral canal has obviously the body of the vertebra up here. This is that spinous process. And then the lamina and kind of these articular processes as well as transverse processes are important. So if you feel like you're off to the side and you're seeing bone, 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 probably on one of these lamina. So if you feel like you kind of go up, 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 down, 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 and it's just bone everywhere, assess, are you right to left? Because that's more commonly that you'd be on one of these lamina than you would be somewhere in that midline spinous process. Transverse process is important when we talk about the paramedian approach. When you're on APS doing thoracic epidurals, sometimes you'll come in, hit this, then back off and kind of come in from that side. But just, I think keeping these kind of spatial relationships in mind can be very helpful when you're actually doing the procedure. Talking about the ligamentous structures, this is up in the C-spine, kind of showing this little route that the vertebral artery passes. We don't do a lot of, obviously, cervical procedures unless you're in the pain clinic. But again, just kind of showing some of these spinous processes and that this is really all ligamentous coming in from the back. To zoom in on that a bit and bring our needle into play here. So obviously this comes up on tests. What are the layers that you're going through? So first one is the supraspinous ligament. Once you go through that, you're into the interspinous ligament, and then the ligamentum flavum. And the ligamentum flavum is really the tensest and densest ligament, so that's when you get the most resistance back when you're doing an epidural. And you kind of, if you hear people talk about, oh, it's kind of crunchy, you can even almost start to hear like little pops as it goes through, especially in young people. And then once you go through there, you don't actually go that far, but you end up in the epidural space right here. When you talk about what are the boundaries of the epidural space, you're looking at the posterior longitudinal ligament ligamentum flavum, and these lamina on the sides. So in this space is where you'd have the epidural space, the thecal sac, and where you'd be depositing either a catheter, the medication, that sort of thing. All right. So vertebral anatomy, again, knowing landmarks externally can be very helpful because if you start in the right place, you're much more likely to be successful, I think. Obviously, finding midline is very, very important, but also knowing a few basic, what level you're at, because this obviously is important when you're figuring out where to place it based on what surgery is being performed. If you're having something in the pelvis, you don't need an epidural placed at T7. But if you're having a surgery that goes from the umbilicus up to the xiphoid, you don't want it at, say, L3 or something like that. So making the appropriate placement based on not just skin incision, but also the organs involved, because they obviously have innervation that is dermatomally important. So I think although it shows T3 up here, I think more important is knowing that T7 is kind of at this wing of the scapula here. Then you can count up. L4, L3, L4 is kind of at the top of the iliac crest. I think this is probably the one we use most commonly. S2, maybe you'll use, but I think that L4, T7, and then if you're feeling kind of right here at the base of your neck, what spinous process are you feeling right there typically? C7. Yeah, C7, T1, right? Knowing that as well, kind of which one you're moving on. And then if you know where T7 is, you can kind of come to the middle and count down if you're trying to place like a 4-5 epidural for a thoracotomy or something like that. I know a lot of you guys know all this stuff already, but again, it's just a good review of the basics for things that are appropriate for neuraxial. So we just kind of talked about this, looking at this C7-T1 relationship, and using that again as a anatomy. This is just a dermatomal map. So again, knowing where you're trying to cover for your operation is important. Not only for neuraxial procedures, but also when we start doing regional, whether it's, is it the medial ankle, the lateral ankle, what type of blocks maybe do we need to do for that patient? You did a femoral catheter for a femur fracture. Typically that would get great coverage because you're looking at L2, 3, 4 for the femoral nerve. But if you're doing a total knee, well, there's still some posterior coverage. That's not going to be a one and done type of a block if you're trying to do a total knee under blocks. Similarly, again, if you're looking at incisions on the abdomen, what exact dermatomes are going to be involved? Where would you want an epidural for that type of surgery? Okay, so getting into the actual neuraxial anesthesia, there's a lot of different things that get thrown out. There's obviously a single shot spinal, an epidural, but then there's also these things called combined spinal epidural, where you're using a 2E needle and then doing a spinal through it, but leaving a catheter. So it's kind of that combined technique. And then something called a dural puncture epidural. Have any of you guys heard of a dural puncture epidural?
Where you purposes poke into the dura and then you pull back a little bit?
So you don't poke in with the 2E, but you poke in with the spinal needle. So it's essentially a CSE, but you're not giving any intrathecal medication. If you use a slightly larger needle, so like a 24 gauge needle, the idea is that you may get some translocation of the local anesthetic, so a little bit better analgesia, but you also get the benefit of, if you get CSF back through that spinal needle, pretty darn sure you're going to put your epidural, at least to begin with, in the midline. And it's pretty hard to thread a catheter into a space if you're getting CSF through that spinal needle and then trying to put the catheter through the epidural needal. There's not a lot of places you could thread a catheter that aren't the epidural space in that setting. So it's kind of both a confirmatory and potentially an analgesic improving technique without some of the downsides of giving an intrathecal dose. But for all of these, they're elective procedures. So keeping that in mind when someone asks you, oh, can't you just do a spinal for this patient? It's not it's never an emergency to do an neuraxial procedure. And you do always have to think about risk benefits, especially when it's one of those kind of muddy situations where, maybe the coags are a little marginal, maybe the hemodynamics are a little marginal, maybe the indication is questionable. All right. So I know you guys haven't done spinal, but have you seen the spinal kit? Has anyone touched spine? Okay, I guess. So really what we're talking about, that all you really need is an introducer needle and the spinal needle. You don't need a whole lot of other things with that. And the introducer needle is really there only because the spinal needles that we use are so small that they aren't essentially stiff enough to go through all those ligamentous structures and get things started. So you need something to lead the way and then use that spinal needle to go through the last of the structures so that it's not bending, it's not getting diverted, you're not totally missing your target. Different types of spinal needles. So the bottom two, the Whitaker and the Sprott, are both fall under the pencil point spinal needle category. And that's important because you can see that the tips, although the very tip is sharp, it's not a beveled edge, unlike the Quincke needle, which we would call a cutting type spinal needle. So in our procedures, which one of these two do you think we use? Pencil point or cutting? Why do we use pencil point? You're correct.
I think it reduces the risk of, post-op kind of headache situation.
Exactly. So we think that having a cutting edge needle is at more risk to cause more damage to the actual dura and arachnoid fibers than the pencil point needle, which, although it pokes in, we think it more spreads rather than just slices that area that it goes in. So we try to only use pencil point needles for intentional dural punctures. Okay. And then when we're looking at epidural catheters, you can see this is a 2E needle, and it is a cutting edge, but we don't, obviously, we're not intentionally puncturing the dura with our 17 or 18 gauge 2E needle. And then we get here, put this catheter in, or this is the combined spinal epidural, put the spinal needle through the end of the 2E, then inject, remove that needle, and then thread that epidural. So just a visual representation of what I was explaining before. All right, so some of the indications for spinal anesthesia. Have any of you guys done cases where your patient got IT morphine from the APS team? What were surgeries that happened for? Okay. Yeah. A lot of open bellies where, honestly, usually the surgeons don't want epidurals, which is fine. IT morphine is a very good post-operative analgesic. We use it actually on OB in all our C-section patients to greatly minimize the number of, or the amount of opioids that they need post-operatively. And it does the same thing in the general surgery population. So it's a really nice option to balance out some of that side effect profile and decrease the amount of parenteral opioids that are needed. Otherwise, we can also use it for surgical anesthesia. What do you think are some of the surgeries that would be good for spinal anesthesia to use for actual surgical anesthesia? C-section, absolutely. Yep, we do that a lot. Total joints, right? Like total knees, total hips. We do spinals a lot for those cases because we want very dense motor blockade in those cases, very dense anesthesia, so the patients won't feel anything, but then we want it to go away pretty quickly. We want them to be able to start their rehab, to be able to get up and move around. Some places are trying to do same-day surgery total joints. We aren't quite to that level yet, but it's a way to do that and not have to have the patient under general anesthesia. There's also some literature in the orthopedic population that it may improve things like risk for blood clot, amount of bleeding, that sort of thing. Other types of surgery you could do under spinal, usually things that are involving kind of below the chest. It would be possible in theory to do something with a total spinal, and even something like minimally invasive coronary artery surgery has been done with thoracic epidurals. It's pretty unusual. We're typically talking about things in the pelvis, lower extremity, orthopedic procedures. Those can all be done with a spinal, but you can't really do an arm surgery with a spinal. You also have to think about duration of surgery. You don't want someone with a spinal, certainly you're kind of limited to that really 2.5, maybe 3 hours if you really give a high dose, and it's slow to recede, you're doing something low, but you're not doing like an 8-hour case under a spinal. In theory, you could do something like a combined spinal epidural, run the epidural, but again, you want a patient laying on a table for 8 hours with either minimal or heavy sedation. Is that really worth it for that patient, for you that you're now dealing with, trying to manage the sedation for that, maybe talking to a patient for that long? I think it becomes a balance of considering all those things. When it comes to contraindications, really patient refusal or patient inability to consent are two pretty big absolute contraindications. If someone's saying, no, I don't want this, well, again, this is an elective procedure. I'm not going to hold you down and force you to get a spinal or an epidural. Coagulopathy. So, this is not quite as contained a space as the cranium, but as people get older, they get more osteophytes. They have less drainage out of that epidural space through the areas of the bony anatomy, and we're worried about things like epidural or spinal hematoma. And so I think knowing patients' coagulation status, especially if they've been on anticoagulation, if they just had surgery where they bled a whole lot, if they're coming in, they're very sick, they have liver dysfunction, that sort of thing. I think it's important to know that prior to placing a block, and at times it may exclude people from being able to have a neuraxial procedure. ASRA has a wonderful app. I would encourage all you guys to get it for your phone. It's like $2 or something like that, and it's $4. Did you say? Okay, whatever. It's a small amount of money, but you can just go in and say like, okay, this patient's on apixaban and I want to do an epidural, and it'll tell you what the timeline is to place the block, place a catheter, remove a catheter, when it can be restarted. It's very, very helpful for all the medications that patients are on in terms of when things can occur. When patients are severely hypovolemic, hypotensive, we worry about dropping blood pressure, especially with something like a spinal where you're going to get a drastic sympathectomy below that block level. Increased ICP, why is that concerning?
Sorry, if you accidentally puncture them, you get like a shift.
Yeah, how does that work? Why does that happen?
There's limited space in the brain.
Okay, so there's limited space in the brain, but you're doing something down here. So why would that cause herniation?
You decrease the volume. Yeah.
Exactly. So you're relying on that CSF to provide a balance and help prevent herniation. And now if you drain CSF, well, now the brain can expand more and it's going to expand down. So increased ICP, especially a big tumor, that sort of thing, we're not going to do any sort of spinal, especially not something where we're going to be, doing an LP in that situation could be pretty devastating. Local infection at the site, we don't want to introduce something right into the neuraxis from a local infection. There used to be a pretty strong opposition to doing spinals in patients with aortic stenosis. I think you still need to be very careful, but because we have some of these other techniques, we can do things like a combined spinal epidural where we have a small dose and then see what happens. We can slowly dose an epidural on top of that. It's not an absolute contraindication. Sepsis or systemic infection, again, not an absolute contraindication. You'd want to make sure that patients aren't floridly bacteremic. Again, worried about introducing some sort of infection centrally. If they've been on antibiotics or afebrile, they're hemodynamically stable, then there may still be a place to get that block in. Pre-existing neurologic deficits are not an absolute contraindication, but I think you need to define what those are, what implications of doing a spinal or epidural have for that type of condition, and document. So if someone has a known, say they had a stroke years ago and they have some motor weakness or some tingling, numbness, do a neuro exam, document it, talk to the patient about it, but that doesn't mean they can't have a spinal for their total knee. And then uncooperative patients. I put relative here because I think that depending on, if a patient got some Versed for their block and now they're uncooperative, that doesn't mean that they still didn't want the block when they were consenting for it, if that makes sense.
It's a good question.
Yeah.
In a pediatric population?
So in a pediatric population, it's a little bit different. Depending on how old the patient is. Maybe if they're a teenager, then we can still typically do these awake. But for small children, typically they're done when they're asleep, which is not the greatest in terms of them being, obviously they can't give you feedback if they get a paresthesia or anything like that, but it's also, you're balancing that out with, you're not going to be holding down a 4-year-old while they're screaming. That's not safe either. So in terms of safety for peds, we do it when they're asleep, consented by the parents. And in very small children, we actually do caudals, so very, very low injections or catheters, well below where the spinal cord is. All right, really quickly. So local anesthetics to know and understand, and when you're choosing, really is going to depend on what your goal is. So bupivacaine is a longer acting or longer lasting local anesthetic than lidocaine is. So for our typical spinals and spinal kit, we have 0.75% bupivacaine that is hyperbaric. So what does hyperbaric mean? It's heavy, right? Heavier than, right, exactly. Baricity is basically comparing the density of a substance or a liquid to CSF. And so we make bupivacaine hyperbaric by adding dextrose to it. Or we don't. The manufacturer makes it that way. In theory, we could create hyperbaric, or the pharmacy could create hyperbaric local anesthetic for us, but it comes that way. We don't have to be adding anything. Again, minimizing the risk of any additional thing that could be an infectious sinitis. Lidocaine, we don't have 5% lidocaine right now. When we did, it is better for those shorter procedures, really, 60 minutes or so. We don't typically use ropivacaine here. You could use it for spinals. And then tetracaine is another longer acting local anesthetic that can be used in spinals. So in terms of duration of block, protein binding, the more protein binding there is, the longer blockade. And you think about that by, if it's going to slowly release and you kind of continually have this low but adequate level as it comes off the protein, then you're going to continue to have block, versus if you just have a lot floating around that binds and then is gone, your block is not quite as long. We can also add some things into spinals. You can add things like clonidine or epinephrine that have alpha-2 agonism properties. Epinephrine in the intrathecal space is acting via that alpha-2 agonism. It's not a vasoconstrictive effect when we're talking about having an additive effect to the duration. And then obviously we add in opioids to help with a separate central modality for analgesia intensity of block. All right. So in reality, there's not a lot of common side effects from doing a spinal. You can get hypotension, but we know that, we anticipate it, we're ready to treat it. Certain medications like opioids can cause itching for patients. Typically, they'll feel a bruise on their back for a day or two, and I think that's important to mention because of this, I had an epidural and now I have chronic back pain, perpetuated myth that goes out there. It's really just, they're going to feel a bruise I tell them it's like a flu shot, but in your back. Anything serious is extremely rare. So things that could happen, post-dural puncture headache, about 1% risk doing a spinal with the size of needle we use, which is a 25 gauge typically. Again, we try to minimize that by using the pencil point needle, by just having one poke. But if it happens, what type of a headache is it? Positional. That's kind of the hallmark. It is very bad when sitting up. It happens very quickly when sitting up. And it should go away almost completely, if not completely, when laying down. Again, it should happen very quickly. And the reason of it is that kind of we talked about the ICP. We need that CSF to add buoyancy. Well, when you get a post-dural puncture headache, we think that situation is intracranial hypotension. So you have something that you're having, either you lost a bunch of CSF at the initial puncture in the initial placement, or you have left a hole or multiple holes big enough to have continual drainage. So you've lost that buoyancy, the brain is sagging, and the brain sagging pulls on the meninges, which have pain receptors, as well as allows cerebral hyperemia, so blood vessel dilation in the brain, which in and of itself is painful. So kind of a multi-mechanistic headache from that intracranial hypotension, which is why when you sit up, the brain sags, everything pulls. It's bad. When you lay down, the brain goes back to its normal position, restore those anatomic relationships, the pain improves. That's far and away the most common of these complications, and we have ways to help it, right? So we can do conservative measures, which may decrease the severity a little bit, potentially prevent epidural blood patch, but really epidural blood patch. If someone has a true severe post-dural puncture headache, we want to get an epidural blood patch. And you'll do those on APS, we'll do them on OB, but essentially what you're doing is trying to help restore that balance and provide a clot to prevent further egress of that CSF to help prevent either worsening or continued intracranial hypotension. Cauda equina syndrome is very, very rare. It happened more when we used high concentration lidocaine in micro catheters in the intrathecal space. And we think it's essentially due to a pooling of local anesthetic around the cauda equina. Because in reality, local anesthetic is slightly neurotoxic. And if it sits there in very high concentrations for a very long time, it's not so good. What is a probably much lesser degree of that is transient neurologic syndrome. You guys heard of TNS? What is it? Real quickly, one-liner.
It's like pain after.
Where's the pain?
I think it's in the lower extremities.
Yeah, it's usually like lower back, buttocks, maybe thighs, and it's like a crampy pain. It's more common in after lithotomy position, outpatient surgery, probably because people are getting up and those muscles are firing. Do you know what the treatment is? Time and NSAIDs. So it is transient, as its name implies, and it's something you can treat. It's not something to be worried about. Again, it's probably due to an injection, and it's more common with lidocaine. So again, that high concentration local anesthetic, probably if you just inject it and then it sits there right at those little fila and those nerve roots, could be a little bit irritating, especially if you're in lithotomy. Now you've created a position where the local anesthetic is going to pool in one place rather than having the same spread as a supine position. So it's something to kind of look out for, but something that we can treat. And then a high spinal, obviously that's going to be when our level is too high, patients get extremely hypotensive. At the extreme, it can cause loss of ability to speak, loss of strength of the diaphragm, so patients can't breathe adequately. And in very fast effects, it actually can cause a respiratory arrest, where you need to support ventilation, potentially intubate the patient until that kind of recedes down. When that happens, it's not that the local is up to the brainstem, but patients get so hypotensive that you hypoperfuse your respiratory center. It is not common, thank goodness, but it is something to kind of look out for, and just be prepared to treat it. It's one of those known complications that you just need to recognize and give supportive care for. All right, so we don't have time to go into this, obviously. Take a look at the app. It's actually, the new guidelines are out. So the document is like 80 pages long, you don't need to read it, but look at the app. You know, if you have a patient that is getting an epidural or getting IT morphine, or you're going to do spinal on and takes any kind of anticoagulation, even things like aspirin, Plavix, if you're bored, just play around with it. It's really interesting to see it summarizes very well what the recommendations are. All right, and for 2 minutes, we're going to go through some questions and we'll run back over to the OR. All right, so neuraxial anesthesia is associated with all of the following except
C.
Yes, exactly. So we talked about lower risk for blood clots. Doing a neuraxial helps avoid parenteral opioids, which are going to decrease our GI function. We do these a lot for nerve blocks, actually a lot for AV fistulas to help engorge the vessels so they can make a better graft. And then we're not really increasing the risk of bleeding, we're decreasing the risk.
So what's the potential mechanism for the clot and the...
So having that dilated blood vessels, so we're having less, I guess we get a little bit of stasis, but it's not in a small vessel. So there's more movement within the large capacitance. Okay, so we got a 30-year-old female who essentially has a positional headache, probably post-oral puncture headache. So this is a question about type of needles. So what type of needle is most likely to cause a headache?
D.
Yes, exactly. That cutting type needle, and it's a bigger gauge than the 27 or the 24. All right. What patient are we not going to offer a spinal to? Yeah, it's pretty hard to make someone comfortable getting a robotic procedure where they're on their head with a spinal. Have you guys done the robotic hiss? The position's pretty extreme, right? Can you imagine a awake patient with insufflated belly trying to cover that with a spinal? Not possible. All right, so we'll call it there. Questions really quick. Sorry, I know I tried to get through a lot, but it's a big topic. Okay. So we'll do, like I said, we'll do a little PBLD this afternoon. We'll play with a whole bunch of needles. I'll show you kind of how I put my hands in. You guys can just play feeling different sizes of needles, play with the epidural stuff, and just get your hands on some stuff. All right, have a good day, guys.